Hi everyone, my name is Simrat. I'm a cardiac imaging fellow at Cleveland Clinic, and I'll be presenting an unusual case of LV mass. I'll be showing a lot of images. I know you guys are hungry to go for lunch, but this will keep you awake. This is a unique case of a 26-year-old healthy athlete. He's a basketball player who was transferred to our institution in college basketball player for further management of newly diagnosed LV mass after he presented locally with NSVT. He has 2 months of palpitations with frequent PVCs and NSVT for which he was started on verapamil. He continued to have these symptoms, so he was transferred to us for consideration of resection of this LV mass. This is his EKG showing progression from normal sinus rhythm to VT with right bundle branch morphology. And this was his echo. And you can see that the mass actually is in the lateral and the inferior lateral segments of the LV. And it actually measures, it's pretty large, it measures 1.9 to 5.6 centimeters. So I just wanted to ask the panel or the audience if they had any ideas and what they would do at this point.
Well, if you want a differential, I can start with that. The common one here that it invades the myocardium of the LV and presents with VT is a fibroma.
So, we were also concerned about that, so we wanted to get further tissue characterization, and we pursued a cardiac MRI. And you can see that the mass was only present in the lateral and inferior lateral wall of the LV. And on T1 imaging, it had similar signal intensity with the myocardium. And on T2 imaging, it had hyperintense signal and also involved the papillary muscle, anterolateral papillary muscle, as you can see on T2 imaging. And on first pass perfusion imaging, it had similar signal intensity, but on late gadolinium enhancement, it had increased enhancement. So all these features were taken into consideration, and while we could not come to a conclusive diagnosis, we were sure that this is likely a benign process. It doesn't distort the myocardium, but it definitely engulfs the wall of the LV. We wanted to see if there were any extra cardiac features, so we pursued a cardiac CT. It's a true multimodality imaging case. And on the contrast cardiac CT with early imaging as well as delayed imaging, you can see that actually there is hyperintense focus in the PAP muscle with lack of enhancement from the contrast, and there were no extra cardiac findings. While we were confident this is a benign process, we weren't really sure what it is, and we needed a tissue. And this is one of the rare cases where we pursued a LV biopsy, fluoro as well as TTE guided, and it showed that there was significant multinucleated cells with some small giant cells which were CD4 T positive as well as CD8 65 positive, and pathology was consistent with actually sarcoidosis. So then we went ahead and pursued a PET which showed there was significant inflammation of the LV wall, inferior lateral wall, which you can also see here on horizontal long axis, vertical long axis, and short axis images with the resting perfusion defect, which is consistent with known diagnosis of sarcoidosis. Here you can see a resting perfusion defect along with FTG uptake in the lateral and the inferior lateral wall, also seen in the horizontal long axis images. And the patient was started on steroids and methotrexate and actually improved significantly, did not have an NSVT, any NSVT or VT again. And as you can see on this follow-up echo, that the mass, which was truly just inflamed myocardium with some fibrosis, resolved. So this was a case of isolated necrotizing sarcoidosis, cardiac sarcoidosis, without any extracardiac manifestations. That's all.
So yes, a fascinating case. When you were showing that mass, I was like, all right, see what Craig says about this mass, right? is in a younger person with a PAC, PVC burden, you're thinking of if more malignant presentation, giant cell, then you think sarcoid, you AVRD, right? You're trying to think these things. But the mass with isolated sarcoid is very, 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 very unusual. Mm-hmm. And then how to tackle it is, remember the assessment. It's definitive based on histology, high probable, or unlikely. And the MRI wasn't going to be diagnostic. It told you, that there was something infiltrating muscle. So I think pursuing, FD to see if there's any active inflammation with the sarcoid concern. The only thing you had was the EKG and the dysrhythmia in a young person. So that may have been useful because I can tell you, having journal club about going after a biopsy, like Mauricio, we can talk about it, right? We're going to do interatrial septum, we're going to go across the aortic valve. We biopsy the LV for research purposes. It's fairly forgiving, but you have to target that one area, right? Mm-hmm. The diagnostic yield is very low. Sometimes you can use some EP guided efforts with mapping. Yeah. So I'm glad. What I like about it is you went after the diagnosis, because that changes the treatment plan, right? And so this is definitive. Now, many people would typically say cardiac sarcoidosis is a myth. Isolated cardiac sarcoidosis is a myth. Yeah. About 5%. So it does exist. This is a even rarer example with the mass. Yeah. But certainly it would guide it would guide treatment with immunosuppression. Yeah.
No, actually, I didn't mention, but this patient was in CICU, had incessant VT.
There it is. You left out the malignant presentation.
The malignant. So he presented just for the resection of the mass, but while he was getting all this workup, he started having VT. He actually got an ICD.
Yeah, so you see any patient, but you see a young patient with a malignant dysrhythmia, think giant cell myocarditis sarcoid. Right. Those come up on the list. Like if you had started there, we would say we have to exclude that as a presentation from a heart failure perspective.
Right. And the heart failure team was consulted for. There were conversations about cardiac transplantation, and I think getting the LV biopsy was crucial here. And it was complicated because there was so much fibrosis that they had to take 5 samples, and ultimately the 5th sample they had ROSE, rapid on-site sequencing.
How was the biopsy imaged? I mean, was that directed by imaging?
So fluoro and TTE.
TTE.
So I can tell you, we've biopsied right-sided masses. We do it with some frequency, and you use TE and imager, do 3D, because you can put that biotome deep in. The bigger the mass, the more safety net. Here, you're in the left side, you're close to the wall, and you really got to get in within that mass, and then you have to worry about the complication. Mm-hmm. The LV is actually more forgiving than the RV. Right? It's thicker, so it's just some dysrhythmia burden, and you want to do it. Do you know if they went retroaortic valve? Or?
They did.
Yeah. That's probably the easier based on the antilateral, because you want that biotome to curve right in. Mm-hmm. So you could do it with a good imaging colleague, and you can get to the area you need, but you're going to have to do, when we do biopsy for inflammation for cellular rejection, we get 4 to 5 pieces. So that doesn't surprise me that you would want to proceed along the lines. In fact, you'd have the pathologist in the cath lab to guide you on your understanding, so you can be aggressive, because you don't want to have to take this person to an open procedure.
Yeah.
So Simrat, in terms of multimodality, you did all the modalities. Just say you were at a smaller hospital and you only had to pick 1 or 2. So you just say, you have your, it's not a board exam, but just say, what was the biggest yield? Obviously, probably what, the PET scan was the
So I think we had some biases going in, because this was presented to us like an LV mass case, and it did look like an LV mass on the TTE initially, and I think we pursued the cardiac MRI, which is crucial. But I'm going to pivot a little bit, and I would say that here the tissue was the issue, and even though we used multimodality imaging and actually all the imaging under our whatever we had, but ultimately we need the diagnosis from the tissue. So I think that in some situations you just have to get the biopsy.
But I think here the FDG PET, the FDG uptake plus the perfusion abnormality makes this probable sarcoid.
Right. But I think, as I mentioned, that it was it was an LV mass. Isolated cardiac sarcoidosis was not a top differential at that time. But like in hindsight, a PET would definitely help with the diagnosis. But the PET would also be would also light up if there's giant cell myocarditis or other forms of myocarditis. So the only way to differentiate would be a biopsy.
Just to go back to when you just had the echo and you saw a mass, what was your differential?
So at that time, we were actually concerned about a malignant process. We just went, yeah.
What else?
So angiosarcoma, malignancy, fibroma. We did not, honestly, we did not think about sarcoidosis until very late. Okay, thank you so much.